Distinguished colleagues, well, similarly to coronary stenting, when endovascular surgeons became very active, started working actively on the carotid arteries. So there was a slogan, open surgery will die soon. But you know, after that coronary stenting was made available to us, nothing died. And each of these treatment modalities played its role. Carotid end arterectomy has been in use since 60 years ago, and the vascular surgeons achieved excellence in performing this procedure, and that's a SVS registry. 226,000 coronary artery endarterectomy. Lethality is less than 0.5%. As for alternative, well, we cannot object. I mean, we cannot deny the development of endovascular surgery. Yeah, that's like a cardinal way of development of modern healthcare. But despite minimal invasiveness, endovascular intervention, especially those on the extracranial vessel, have their, like reverse side, and that are mentioned in the guidelines and the registers we're talking about. As for results of the randomized clinical trial, well, previous presenters touched upon that, so I decided to present them as a very simple bars diagram. Well, those are the randomized clinical trials, RCT. Sapphire, the earliest one. As for other RCTs, as you see, number of patients enrolled exceeded several tens of thousands. As for primary endpoints, MI and death, the carotid end arterectomy is superior. As for space, no statistical significance. As for crest, again, carotid end arterectomy is superior. Rate of non-fatal stroke. The RCT shows that after carotid end arterectomy, we have fewer non-fatal stroke. Restenosis, again, carotid end arterectomy is superior. Crest conclusion. Probably that's the most reliable trial as of today. Stroke is seen after carotid stenting. MI is seen after carotid end arterectomy. What's important? But its impact on quality of life is less as opposed to that of stroke. That Mayo Clinic also performed meta-analysis of clinical trial, 11 randomized clinical trials. Well, that's Greece, not Mayo Clinic, University of Athens, Greece. Yeah, the risk of death is higher within 30 days after the intervention. That's Mayo Clinic meta-analysis. In each 1,000 carotid endarterectomy will have 19 extra strokes as opposed to stenting will have 19 extra strokes as opposed to carotid endarterectomy. As for cost effectiveness of this manipulation, indeed we compare carotid stenting with carotid endarterectomy, since again this manipulation has been in use since long ago. And we have to tell you that in the long run the results of those meta-analyses I quoted, demonstrate the superiority of carotid endarterectomy. As for limitations uh, for carotid stenting, CAS. So by data of US scholars published in 2011, that's the data of the Georgetown University. That's a patient with stenosis from 50 to 90% at high risk for CEA because of anatomic or medical reasons. That's an opinion of, again, scientists, Paraskevas et al. Is rather radical. What do we need stenting of carotid arteries for if we have carotid endarterectomy that is associated with a lower risk of stroke and which is more cost effective? That's again the data from derived from the United States and Russia on the cost of CEA versus CAS. Well, it's a twofold different. As for our country, that's an approximate cost of endarterectomy 30,000 rubles, and stenting cost 4 times as much. Because of our financial constraints, we have to take it into consideration. As for, again, the European guidelines, that's a ratio of stenting and endarterectomy, CA versus CS. Those are the rather old, obsolete, if you wish, guidelines of the European Society of Vascular Surgeons. And Professor Albeck and myself took part in discussing these guidelines. Unfortunately, the most radical point of view prevailed. Practically, there were no indications for CEA. Oh, no, sorry, CAS. But that time, we didn't have the results of the CREST trials, and I'm not going to go into detail. In 2011, the guidelines of the United States American guidelines were released. That's it's a consensus statement. So many professionals took part in the development of this guideline. And among other international guidelines, these particular practice guidelines are the most important ones. These recommendations contain, again, justification or rationale for carotid endarterectomy and the conditions circumstances under which CAS may be preferred. Clause number 3. In case of unfavorable anatomy of the neck for open surgery, stenting is preferred as opposed to CEA, and the level of evidence is B. Yeah, it may be performed in a selected group of patients, including those with asymptomatic stenosis. One of the conclusions of these guidelines: currently, with consideration of advances of pharmacological therapy, CEA and CL should be not only compared with each other, but also with the results of optimal medication therapy. To conclude, at the conclusion of the CREST trial, so CIS is an alternative of CEA, and one of the comments made in 2011. So an alternative may be construed in an erroneous manner. It's not like an equivalent, it's alternative. But maybe just a play of words, but we have to keep it in mind. As for the most recent guidelines, those are the national guidelines on managing patients with the brachiocephalic arteries problems. That's also the consensus statement. As you see, several Russian national scientific societies participated in the development of this guideline. I have to tell you that among the developers, leading Moscow endovascular surgeons, academician Ilikan, professors Kovteladze, Bugov, and others. So Vladimir Vasilyevich and myself also took part in the development of this guideline and had very hot debates with our colleagues and the vascular surgeons. But finally we reached into consensus and developed like the statements or, built our national guidelines and the uh, ratio CA versus CS. What do our national guidelines say? The high-risk patients with cardiac complications are not contraindicated for CA. As for the patients at higher risk with symptoms, probably should not undergo either of this procedure. Carotid endarterectomy is associated with the emboli, risk of emboli in elderly patients. As for stenting, well, it shouldn't be even performed if the overall risk exceeds 3% in the institution. Well, that's what's known from the international guidelines and may be derived from this randomized clinical trial. And maybe that's the most important portion of guidelines regarding, again, a ratio between CA and CAS. We believe that stenting is indicated in restenosis after CA if contralateral brain cerebral nerves are affected. Then anatomical recommendation, the high position of the carotid artery bifurcation when it's difficult to mobilize it, and another recommendation. But again, the endovascular surgeons insisted on it. So CIS may be performed with degree of caution in case of unstable of plaque. It's not recommended in the case of disseminated extended calcinosis and in case of complicated anatomy of the aortic arch. Conclusion. Well, basically, I'm supposed to be an opponent of stenting, but as a matter of fact, I'm not against it. We just shouldn't perceive this method as the rivals, as competing. So we have to rely upon our common sense and patient interest. Long life